Hello, and welcome to the 7th Annual AAKP Global Summit on Kidney Disease Innovations. Theme: The Decade of the Kidney at Midpoint, Opportunities and Barriers to Greater Innovation and Freedom from Disease and Disability. This annual event is proudly hosted by the American Association of Kidney Patients in collaboration with our allied partners at the George Washington University School of Medicine and, and Health Sciences. My name is Richard Knight, and I am honored to serve as the immediate past president of AAKP. I am a transplant recipient of 18 years. I also serve on the board of the Personalized Medicine Coalition, the Xeno Advisory Committee, the Kidney Precision Medicine's Community Engagement Committee, the COPE AAKI Project, and Critical Path Institute's Biomarker Data Repository Oversight Committee, all thanks to my involvement with AAKP. Being involved with AAKP enables me to maintain a high level of participation within the kidney patient community. It also provides me with up-to-date information on legislation related to kidney healthcare issues. The added credibility of my involvement with AAKP, it simply enhances my value as a speaker and allows me to engage with healthcare providers in a very meaningful way. Since 2019, the Global Summit has served the global kidney community as the largest patient-led kidney disease innovation summit in the world. This year's Global Summit marks a critical milestone because it is the midpoint of the AAKP-led Decade of the Kidney, an initiative that I had the pleasure of working closely with fellow AAKP leaderships during my presidency to develop and announce it. The global effort has been mirrored across the world by kidney advocates, medical allies, government officials, and among people of goodwill committed to return to true patient-centered medicine. Throughout the first half of the Decade of the Kidney, we have raised awareness about increasing burdens of kidney disease worldwide among people, communities, workforces, and governments. This effort has also accelerated the determination to transcend the status quo of treatments, including brick and mortar dialysis. We look to a future kidney care that will be determined by expansions in patient consumer choice, targeted therapies that stop kidney disease and prevent kidney failure, greater access to donated organs, new devices, and alternatives to human organs, including artificial wearable and implantable kidneys and xenotransplantation. We believe the time is now as we move forward the next 5 years of the Decade of the Kidney. For patients, for care partners, clinicians, researchers, innovators, industry, and government leaders, it's time to accelerate our bold actions to push forward modern diagnostics, devices, and therapeutics, and continue to remove outdated practices that block their adoption. No country is immune to the impacts of kidney disease. But the great news is every person watching has a role in shaping a future for all people who are at risk for or living with kidney disease that offers more hope, better outcomes, and greater independence and freedom from disease and disability. With that, I'm honored to serve as a moderator for today's sessions: Patients, Quality, and Payment Systems. Why the Patient Voice Matters. We are fortunate to be joined by three outstanding speakers. First, we welcome Dr. Sven Berg, Chief Executive Officer of Quality Insights, a nonprofit organization dedicated to improving health and healthcare. Following his distinguished service in the United States Air Force, Dr. Berg joined Quality Insights in 2011 as Chief Medical Officer, where he provided clinical oversight across all projects. In 2016, he was appointed CEO. In this role, Dr. Berg leads the organization in advancing its mission through three strategic pillars: serving as a change agent to drive transformation, acting as a connector to build systems that optimize health, and functioning as a decision partner to translate data into actionable items. Joining Dr. Berg is Timmy Nelson, an AAKP member and kidney transplant recipient from Pennsylvania. Timmy received the gift of life in 2017 from a deceased donor and has since become a passionate transplant advocate. He actively participates in several organizations working to support others in the early stages of their transplant journey by sharing practical advice and encouragement. Much of the guidance he received from his own transplant coordinator. Dr. Berg and Timmy, I will turn it over to you.
Well, thank you, Richard, and thanks to the American Association of Kidney Patients and GW University for this great opportunity. I'm presenting today with Timmy Nelson, and he has a powerful story to tell. However, before he tells his story, I'd like to briefly introduce you to Quality Insights, where our purpose is simple and straightforward, but that's to improve health and healthcare. Quality Insights operates as a catalyst for data-driven healthcare quality improvement. We serve multiple regions across the United States. Our geographic reach is quite extensive. We cover 9 states and U.S. territories through our end-stage renal disease networks. This includes the unique challenge of serving the Caribbean islands with our multilingual staff. At the heart of our kidney disease work is our unwavering commitment to patient and family engagement. We maintain robust patient advisory committees whose input shapes every aspect of our programs. This patient-centered approach is exemplified in our kidney care initiatives, where since 2020, our networks have helped transition nearly 9,000 patients to home dialysis, supported more than 7,000 patients in receiving kidney transplants, and we've added approximately 9,000 patients to transplant wait lists. One of our flagship programs is the 5 Diamond Patient Safety Program, which has reached more than 3,000 facilities nationwide. This program helps dialysis facilities increase awareness of and build a culture of patient safety through educational content on 19 different safety topics. What truly sets our kidney care work apart is our innovative patient mentoring program. This program, which began in Network 4, with Timmy as one of our pioneering mentors, connects patients and peers who share similar experiences. It operates almost like a Match.com for kidney patients, but for mentoring, not for dating. Patients can find someone with a similar journey to provide guidance and support. An equally important aspect of our work is our grievance process, which provides patients a clear path to address concerns about their care experience with a trusted third party. I am excited to be here with Timmy today because his story exemplifies why the patient voice is so vital in everything we do. Quality Insights tries to be more than just a healthcare improvement organization. We aim to be a change agent, a connector, and a decision partner in transforming healthcare for everyone. Thank you. And now I'll turn it over to Timmy to share his remarkable journey.
Thank you, Dr. Berg. As Dr. Berg mentioned, my name is Timmy Nelson, and a little bit about my history. I was diagnosed with kidney disease in January 2013. I began peritoneal dialysis in December of that year. I was waitlisted in April of 2014 and received a transplant July 2017. That means this July will be 8 years since I've been transplanted. Now, my first outreach was in October of 2017, shortly after my transplant, and that was coordinated by my post-transplant nephrologist. Since then, I have been an active part of ESRD Network number 4, working as a patient advocate and also on the medical review board, and also had the honor of being on the Quality Insights board from 2019 to 2024. And back to you, Dr. Berg.
So, Timmy, in conversations that you and I have had, you've discussed and described a strong, trust-based relationship with your primary care provider that actually began before your diagnosis with kidney disease. Could you tell us how that partnership shaped your experience throughout the entirety of your kidney care journey?
Thank you, Dr. Berg. And yes, when I relocated to Westchester, Pennsylvania in 2003, I needed to find a new PCP. I purposely sought a person that I could build a relationship with, a person I could talk to about my healthcare, a person I could have a healthcare partnership with. I did find that person in Dr. Squire, the person that became my PCP, who has since retired. One of the things I learned about her is that she paid an interest in the things that I was concerned about more than just healthcare, because she realized that building that relationship with me was the key to getting the results that she needed to get from me. Because the goal in many cases is, how do I get the patient to engage in what needs to be done? The result of that was, as I needed other providers or specialists, she was my referring source. And sometimes those partnerships included dentists, podiatrists, dermatologists, neurosurgeon. And then in 2013, I went back to her because I needed a nephrologist. Dr. Berg?
Thanks, Timmy. After you were diagnosed with kidney disease, you made a choice to choose peritoneal dialysis. How did your sense of responsibility and partnership with your care team influence that decision?
Dr. Berg, when I determined, or when it was determined for me, I should say, that I needed a nephrologist, I went back to my PCP and had that conversation with her. I said, who is the person that you can help select for me that fits the way I want to interact with my care provider? And she and I talked about dialysis modalities. We talked about my current health. We talked about me having the ultimate responsibility for making sure that dialysis was a process that worked for me. And she told me she would share those things with a person that she would, in a sense, interview to see if this person she thought would be the right fit for me. Well, she did that, and then I had the same conversation with the person she referred me to go to. We had a conversation about dialysis modalities. We talked about what dialysis means, and one of my partners who has since passed on coined the phrase that DML, dialysis means life. And in fact, it does mean life, because your kidneys function 24/7. In my mind, I chose peritoneal dialysis because my prescription was going to be 9 hours per day. That would be as close as possible as I could get to having actual kidney function by doing peritoneal dialysis. Also, peritoneal dialysis was under my control. It was up to me to address any concerns that I had with dialysis. So if I had a situation where I had water retention, I was trained how I could use different solutions to reduce the concern of water retention. I also learned with some research that this was a method preferred by most providers should they have to go on dialysis. Now, the thing that I learned also is that if I strictly follow the training instructions, there should be minimal concerns. So my goal was to focus on peritoneal dialysis that closely related to me having actual kidney function, and follow and trust my training. Dr. Berg, back to you.
Thanks, Timmy. And one of the things that really impresses me about your story is just the great partnership that you had and actually finding physicians who you could really feel like you were partnering with. In so much that I believe that they made you a better candidate for transplant. And I think your care team actually encouraged that you become a better candidate for transplant each year. So tell us a little bit about that, and tell us about what maybe measures or what feedback that was given from your care team, why that made a difference to you. What meant the most to you during that period of time as you were striving to make yourself a better candidate?
Dr. Berg, thank you for using that term, better candidate, because that's exactly the term they used to me during my pre-transplant period when I was going through the coaching and counseling and going through the testing process to make sure that I was a good candidate. The response was, after my first visit, you're a good candidate. However, we need you to be a better candidate each time. And that better candidate was focused on a couple of things. It was focused on me having better lab work results, me doing better with my stress tests, me being able to better verbalize what CKD, what dialysis, what transplant, what post-transplant is all about. It helped me to better understand why weight management was important and why it was something I needed to focus on. It made me understand that my diet was a key component as to what my health would be. We talked about exercise, how important that is. We talked about our mental acuity. We talked about me being able to adjust my life goals and me being psychologically stable to go through what I need to go through. This is major surgery. No matter how often it happens, it's still major surgery. And my goal was to be a better candidate, in essence, to help my providers do a better job of helping me.
Thanks. It wasn't really just your physicians who were taking care of you. It was really the entire care team that I really sense in my discussions with you had an impact on you. And in one discussion, you were talking about your peritoneal dialysis nurse and how that nurse talked with you about mindset and discipline. How did the psychological and procedural responsibility of home dialysis affect your engagement and outcomes?
Dr. Berg, when I went to see Jen, my nurse, who also has since retired, when I went to see her, I had to stay in the waiting room at first until it was time for my appointment. And I say this with total respect, but what I witnessed in the waiting room made me really be concerned about what kidney disease was going to create for Timmy Nelson. Was I going to go through a metamorphosis and be a different person? I tried to be a positive, upbeat person. And I had some concerns with what I saw and heard in the waiting room. When Jen asked me to come back to meet with her, before she started training me on the process of peritoneal dialysis, I asked her to pause for a second, and I shared with her some of the concerns that I witnessed in the waiting room, some of the attitudes, some of the comments, what have you. Jen listened to me. She heard me out. And then she expressed her concern about me being able to strictly adhere to my peritoneal dialysis regime. And so I explained to her that this regimen will work out great for me. She said, but do you have the right mental attitude to do that? I said, what do you mean? She says, you need to focus on strictly what Timmy Nelson needs to do to be the best dialysis patient also. Here's that term, better and best again, the best dialysis patient. And if you do those things, you will be just fine. In fact, you'll be even better. So we talked about my work travel schedule. We talked about my self-health evaluation process that I do on a regular basis. We talked about, most importantly, my mindset, my attitude, my choice. And something that Jen said to me that day will stick with me forever. When I asked her about, am I going to morph into something that I don't want to be? Her response to me was, only if you choose to. So here again, having that dialogue with the provider helped me to make a determination to maintain Timmy Nelson's positive outlook and to keep me engaged and to better understand and manage my process. Thank you.
Timmy, I really, really like your story. And, you've had remarkable caregivers. And really, as I listened to your story and really the mindset that you developed and the goals that you developed for yourself, you're a remarkable patient as well, and a great example of how patients can become engaged in their care and make a difference in their care. One of the other advantages that maybe you had is that you had supplemental coverage for your healthcare needs. But as you have engaged as a patient mentor with many patients with kidney disease, you've mentioned that in speaking with them, many had concerns about transplantation due to payment issues, particularly in the past about immunosuppressant medication coverage. In your opinion, how important is it for providers to understand the full context of a patient's situation, including the financial considerations that they're facing?
Dr. Berg, first, my thanks to you and Network 4 for allowing me the opportunity to actually go out and visit dialysis facilities in 2018 and in 2019. I spoke with a large number of patients one-on-one, and I learned some things that I had no idea of before, and you kind of touched on it. I was fortunate to have supplemental coverage for any health expenses, and so I had no concerns about the financial aspects of my treatment. I learned quickly from talking to patients that's not always the case. And in fact, one example I'll share with you is that I spoke with a number of patients, and I do mean a number of patients, and they were not considering transplant for one simple reason, because they knew that there was a 3-year limit on their immunosuppressants. And this is before the legislative change that provided coverage for lifetime. Instead, it was 3-year coverage for immunosuppressants. They knew that after that 3 years, they did not have the financial means nor the financial support to continue paying for those medications that you must have to maintain your kidney function. So many of them chose not to, at that point in time, consider a transplant. Now, it was disheartening for me, but that's when I quickly learned that not all patients have the advantages that others may have. So we as providers, and I count myself as a provider in this case only because I'm providing support for the folks, but as providers, find a way to help patients understand the challenges they face and also help them understand possible solutions. So I say that because this healthcare partnership continues post-transplant. It continues for the rest of your life. And this partnership means that patients need to be able to share their concerns. They need to share those concerns that are relational, those concerns that are health focused, or in this case, it was a financial concern. Some patients may not be as receptive to their role until they see the long-term benefit. So when patients have these concerns, whether it's financial, relational, or any other issue, they may inhibit them from being that best post-transplant patient or dialysis patient even. That's where it's so important to have that dialogue, that relationship, that healthcare partnership that I referred to in the very beginning. That's why it's so important to have that relationship so that patients understand that when they have questions, they can get answers and viable solutions to the best of the provider's ability.
You know, I really appreciate your answer, and it's really based from a patient perspective. And, you know, being a provider myself, I wish that all my patients were like that. But I will say, I think the other thing that's really important with regards to that is, as providers, we need to remember the context of our patients as well and really try to understand them so that we can really focus as a true care team. Moving beyond transplant, Timmy, I'm curious how your relationship with the healthcare system has changed. You know, for example, what advocacy work are you doing now? What concerns have you heard from other patients about barriers to transplantation, or anything else that you would like to talk about regarding your post-transplant journey?
You know, Dr. Berg, one of the things I learned during the process, and even especially post-transplant, is that it's important for me to openly share, not force, but openly share my kidney disease journey. I endeavor to be a resource for patients. That's my goal, to be a resource for patients and also caregivers and also providers. Because what I've learned that the message I send to patients is basically the same message providers are sending, but they're hearing it from a patient, someone who's gone through the process. And so that gets their attention in a different way. You know, patients and providers respond differently and possibly better when they know you're a member of the transplant club. I often hear and engage in conversations about social support, conversations about the knowledge of the dialysis process all through post-transplant. I hear about the challenges of the personal challenges, the relationship concerns, decision-making, basically the non-medical barriers are the things I hear about and engage in. Now, to that point, I always clarify that when there are medical questions or concerns, I am a patient. I am not qualified to provide medical advice. So I assure all providers and I reinforce with all patients that if there's any medical concerns, I will refer them to the right person, However, I'm here to discuss things that are non-medical. And so what I've learned when I do that is that it guides those patients back to their provider, and it gets reinforced because they've heard this before, but it gets reinforced with them that for the non-medical things, let's have a conversation about it. I'll share with you what I went through and possibly how that can support you. But when it comes to the medical portions, we need to make sure we stay with the professionals, the individuals that have the knowledge and the experience to answer those questions.
Timmy, are there any particular experiences that you've had as a patient mentor that really kind of stand out, that just bring a lot of joy to you because of, the experience that you've had? Maybe you feel like you've made a change. Anything stick out to you?
There's one situation that pops my mind very quickly. I was in Western Pennsylvania and had a patient. I was doing a clinic talking to dialysis patients about the possibilities of transplant. I was about to leave for the day, and a lady comes figuratively running into the door. I mean, she was just rushing to get into the door and introduced herself. And she asked me who I was. She said, "You're Timmy Nelson, right?" I said, "Yes, I am." She said, "I'm so glad I called." She said, "Today is not my dialysis day, but I wanted to come and talk to you. I read your story. I wanted to come talk to you." I said, "Well, by all means, let's have a conversation." She had been on dialysis about 7 years at that point in time. And so she asked questions about different modalities of dialysis. She was an in-center patient. So she asked questions about different modalities. She knew I had done PD. Asked how the process worked for me. I shared with her my travel schedule. I shared with her I was on a plane 3 or 4 times a week, and I always did my PD because here's my process that I followed. I explained to her that you can travel with PD still. And I explained to her that the key with PD is to trust your training. Stick with your training. And then we talked about transplant. And she asked about how that process worked for me, what it meant to get on the wait list, and how that process worked for me. I explained that to her and shared with her that I had been successfully transplanted. I felt wonderful. Here's what I went through. Again, following the instructions of my providers, doing the things that I'm supposed to do also as a patient. Things have worked out very well thus far, and I anticipate the same for the future. The great news about this conversation I had with her, I learned shortly after she and I had that conversation, she inquired about and began peritoneal dialysis. Now, she had been on dialysis for about 7 years, so her time on the wait list had built up. Shortly after she did peritoneal dialysis, she also got on the wait list, and within about 6 months, she was transplanted. So that tells me that the conversations with the patients do work. It's a matter of sharing your story with them, being upfront and being focused, and letting them know that, yes, you too can do this, but here are some things that you as the patient need to do to make sure you drive the process, because you are, after all, the captain of your care team.
I appreciate that. And that must have just felt just incredibly, rewarding to see the impact that you made. I have one last question for you. Based on your journey, what advice would you give, not to patients, but to healthcare policymakers about making patient voice central to quality improvement and to patient reform?
Dr. Berg, great question. And here's how I'll respond to that. Trust, the trust factor. That's a huge key. Knowing that my provider is going to be looking out for me and what's best for me throughout the entire process. They're going to have dialogue with me. A patient will have dialogue with you if they understand what you're saying and believe that you really do care. I also would suggest checking for knowledge about the processes, checking for knowledge about dialysis. Do you understand the modalities and how the processes work for different modalities? Preparation for transplant. It's more than someone talking to you about getting on the wait list. There are things you need to do to be on the wait list. There are things you need to do to prepare for transplant. And that's what the wait list is all about. Are you watching your diet? Are you watching your exercise? Are you adhering to your dialysis prescription? Are you eating right? Post-transplant. Do you understand the process of post-transplant, the things you must continue to do to make sure that kidney is safely inside you and working properly, and this includes talking with the patient's caregivers many times. I also would suggest, and I think this happens, but as a reminder, take a look at demographics, take a look at socioeconomic, take a look at some of the psychological factors between the evaluation, the visit, the attendees, and sometimes those are the things that cause absenteeism and patients not adhering to their schedules. Take a look at those issues to see if there's something that's missing there that the patient may need to be a better patient. Now, both the attendee and the patients are concerned about the financial burdens of transplant. So keep in mind that when you talk to the patient and their caregivers, the financial burdens of transplant, if there's questions there, perhaps answer those questions to the best of your ability and to refer them to the right sources. Because one of the things, even though I did not need financial support, it was explained to me that if I did, there were resources for me to reach out to and have that conversation. Now, the concerns and the perceived knowledge are important and they correlate to the behavior. So if their concerns are addressed, if the knowledge that you perceive they have, you verify they do have, that correlates to the behavior because they better understand now. And more than likely, their consideration to doing the things they're supposed to do is going to be far stronger than whereas if they were unsure about what needs to be done. Also, prior medical experiences may influence a patient's ability to complete the kidney process. Do they have comorbidities? How do those comorbidities impact that patient? So I ask you to take a look at those kind of things. Take a look at gender, take a look at ethnicity, take a look at the socioeconomic status, and determine whether or not these are issues that may inhibit the patient from doing the things they're supposed to do. When patients don't do what they're supposed to do, often there's a reason, but it goes back again to that perceived partnership. Help a patient understand that, yes, I am your partner in your health. However, there are things that you need to do also. Help them identify and possibly address some of those barriers.
I appreciate that, and you bring just such a wealth of information, both through your own journey and also through the experiences of other patients that you have engaged with as well, to really understand how each journey is really unique. And so as, policymakers are looking at how care is provided and what support is given, I think that those who are listening to this presentation can really see the value that the perspective of the patient can bring, particularly an engaged patient, and how that can really be informative to policies that are developed, support that is given. And so thank you, Timmy. It's been great presenting with you. I appreciate all of the perspective you bring. And Richard, I'm going to turn it back over to you for any questions that you have for us.
Thank you both for your insightful presentations. Before we move on to our next presentation, I'd like to ask you both a few questions. Dr. Berg, barriers still exist when it comes to ensuring patients are meaningfully engaged in the design and evaluation of healthcare services.
Thank you for that excellent question. Despite progress, I really believe that several barriers continue to limit meaningful patient engagement. First, there's the issue of representation. Timmy's story is powerful, right? But we have to ask ourselves, who aren't we hearing from? Often it's those without resources or who face language barriers or just don't feel comfortable speaking up. Second, too many organizations are just going through the motions and view patient engagement as compliance check marks. Yep, we talk to patients, box checked. That's not real engagement. Third, there are practical barriers of time and resources. Patients are managing complex health needs, jobs, families, and then we say, hey, could you join our committee? Could you join our support group? Could you provide input? Without proper support and compensation, we're creating barriers to participation. And honestly, healthcare can be intimidating. There's a power dynamic that makes it hard for patients to challenge their providers or to challenge the system. Through our patient mentoring program, we've seen how peer support can empower patients to articulate their needs and their preferences. These barriers aren't insurmountable, but addressing them requires deliberate effort to create structures where patient engagement is not just welcomed, but valued as an essential component of healthcare design. Thank you.
And Dr. Berg, I have one more question for you. In your view, how can federal agencies and payers better integrate patient-reported outcomes and experience into value-based care models?
Thanks again. I believe that the most effective value-based care models will balance clinical expertise with lived experience. So let me suggest several key strategies. First, we need measures that are standardized, but at the same time, not simplistic. Yes, we need consistent data, but one size fits all doesn't work when every patient journey is different. Second, federal agencies need to put their money where their mouth is, literally. Reward patients who take time to collect meaningful feedback and actually use it to improve care. Not just satisfaction surveys, but real conversations about the quality of life. Third, let's be transparent about how this information is used. Patients share their experiences, and then what? What happens? They deserve to know how their input shapes policies and payment. That builds trust, as opposed to the frustration of not really sensing that what you say makes a difference at all. Fourth, investment in accessible reporting technology is crucial to overcoming digital divides and health literacy challenges. Finally, and I think most importantly, we need a paradigm shift from viewing patients as data points to recognizing them as partners in defining value. This means involving patients like Timmy, not just in reporting outcomes, but in designing the very measures that evaluate healthcare quality.
And Timmy, as someone who's navigated the transplant journey firsthand, what part of the system made you feel most heard as a patient? What part felt most frustrating or overlooked?
Great question. You know, being heard means I'm included. And so the part that made me feel most heard was when my providers included me in the process, when they spoke with me about what I was going through, when they made sure I understood what they tried to share with me, when they did listening checks. You know, the dialogue that I had with my providers had components of factual information, plus listening and responding with empathy, not sympathy, not false hope. You know, I think about my visits with my nephrologist, with my PD nurse, Jen, with my pre-transplant and post-transplant coordinators. And today, with my personal nephrologist and my Penn Medicine assigned nephrologist. I am heard because they include me in the process. They talk with me about the process. So I better understand. Frustrations, there's some frustrations that include loss of control. When you go through dialysis, there's a loss of control. When you get transplanted, you've got some of that control back. You know, the physical, the emotional strain, the challenges, the realities, life, social life, work adjustments. Now, these are things that maybe you can't fix, but there are things that I need you to hear and help me walk through that process some way, shape, or form.
And Timmy, you mentioned wanting to relieve the stress of others starting their transplant journey. What resources or policy changes do you think would make the biggest differences for patients early on?
The first thing to relieve stress of patients, and this is a relational comment I'm going to share, is the patient has to understand the process of I am ill and the doctor will help me fix it, but not I am ill and the doctor's going to fix it for me. The patient needs to understand that I'm ill and the doctor will fix it is far from accurate. It's a partnership. It's a partnership with your providers. It's a sincere, honest, constructive support from caretakers. And that sometimes it means being corrective. So that's the second thing. Your caretakers and the folks that are working with you have to be upfront honest with you and to sometimes be corrective. It's also accepting your responsibility for participation in your role as a patient. Again, this is not a situation where you go to the doctor and they tell you that you're ill and you look at them and say, okay, fix it for me. That's not the way this works, especially in the case of a kidney patient. Diet, exercise, life choices, constructive communication with others and your providers. And still, let's be honest, there's no guarantees. But to get the best possible outcome, this is what needs to be viewed as a team endeavor.
And finally, as we reach the midpoint of the decade of the kidney, how can patients more effectively and deliberately advocate for themselves over the next 5 years to ensure their voices are heard and meaningfully considered by federal agencies and decision makers?
Advocating for yourself as a patient starts with an old expression that I'll share with you, but it's something that needs to be revisited, in my opinion. And the expression is, nothing about me without me. For patients to be a part of that process, they have to be included square one and through every step of the process. There's also a need for constructive, educational, and concern identifying solution-focused patient and caregiver support groups. That's a mouthful. Support groups, but they need to be constructive, educational, concern identifying, and solution-focused. And the final thing I'll mention is identify and develop patient advocates. I truly believe that there is place and there's a role for patient advocates. And when I say patient advocates, a diverse group of patient advocates, a diverse community of patient advocates, people that understand different walks of life, come from different backgrounds. But when you find the right patients that are willing to be these advocates, that can help make a difference. Dr. Berg, to you for your comments.
So Timmy, as usual, I'm always wowed by your answer, and with you as a patient, you have the greatest perspective on that. I will say that this is a very timely question. You know, we're halfway through this decade of the Kidney Initiative, and I think we've learned a lot about what works and what doesn't when it comes to advocacy. I believe that the most effective patient advocates will combine personal experience with strategic engagement while building coalitions across patient populations. First, there's the real power in working together. One voice can be dismissed, but hundreds or thousands of voices, that's harder to ignore. So that's why organizations like AAKP are so vital. They amplify what might otherwise be whispers into a chorus that demands attention. The patients also need to be at the table where decisions happen. I'm talking about federal advisory committees, public hearings, meetings with elected officials. I've personally seen firsthand how a patient's story can completely change the conversation in these types of settings. As Timmy showed us today, there is knowledge that comes only from living with kidney disease that no amount of medical training can provide. I'd also like to encourage patients to get comfortable with numbers and metrics. When you can speak the language of data while also sharing your personal experience, that is a powerful combination. And let's not underestimate the power of storytelling. But not just any storytelling. Stories that point to specific changes needed. Quote, this happened to me, and here's how policy X could have prevented it, unquote. When patients connect personal experiences to specific policy changes, decision makers have both the emotional motivation and the practical direction to act. Finally, I would like to encourage the use of every platform available: social media, patient forums, traditional media. Your experience matters, and in today's connected world, you have more ways than ever to share it. The next 5 years of the decade of the kidney can be transformative if patient voices lead the way. The question isn't whether patients should have a say in their care. It's how we remove every barrier to making that happen. Let's ensure that the patient voice grows not just in volume, but in influence, fundamentally reshaping kidney care in this country. Thank you.
Thank you again, Dr. Berg and Timmy, for your thoughtful responses and for being part of today's important session. We are grateful for your participation. Next, it's my pleasure to introduce our final speaker, Dr. Christina Suh. Dr. Suh is a general pediatrician who has spent her career developing primary care to low-income children. She currently serves as the Director of Clinical Affairs at Phreesia, where she provides clinical expertise in social determinants of health, primary care, vulnerable populations, and the patient activation measure, of which she is here to talk to us about today. Please join me in welcoming Dr. Christina Suh. Doctor, I'm going to turn things over to you.
Well, thank you so much, AAKP and George Washington University, for having me here today. I am really pleased to be here to talk about leveraging patient activation to improve kidney health. So here's a look at our agenda today. So I'll spend a little bit of time at the beginning introducing the concept of patient activation and the patient activation measure. Then we'll talk about patient activation and leveraging it in patients who are high risk for kidney disease. Then we'll end our time today talking about patient activation and leveraging the patient activation measure in patients with chronic kidney disease and end-stage renal disease. So first, I'd just like to start our conversation today by focusing on the patient journey. I just want to spend a bit of time talking about the value of empowering patients through activation. So for a patient like May, at every phase of her kidney care journey, there are many steps and decisions that a patient must make. To help May get to the best outcome for her and for health, we need to rely on her knowledge, skills, and confidence to be engaged in the process of decision making and also taking steps to improve her health so that she can make the best decisions for her. Patient activation really impacts every critical moment for May. So when her PCP tells her that she has chronic kidney disease, or when she's referred to a nephrologist, or when she's prescribed a new medication and instructed to make health behavior changes, such as changing her diet or increasing physical activity or stopping smoking, or when discussing advanced therapies such as dialysis or transplant. So I'll start off by introducing the concept of patient activation and the patient activation measure. The patient activation is an individual's knowledge, skills, and competence to manage their own health and healthcare. And the patient activation measure, or the PAM, as we like to call it, is considered the gold standard for measuring activation. You can see here that it's been featured in over 850 peer-reviewed studies. It's in use by many healthcare organizations, and it's also in use in several quality models and value-based care models. What we know from the literature about the patient activation measure is that it reliably predicts some important patient outcomes, such as medication adherence, preventative health behaviors, unwarranted ED visits, and hospital admissions and readmissions, and also patients' satisfaction with care. So this slide just shows some of the PAM research that is relevant to nephrology. There's a pretty robust body of evidence for PAM in patients with kidney disease, and this slide just highlights some of the key findings from the literature. So you can see under improved health outcomes that higher PAM scores have been associated with better clinical outcomes, such as improved kidney health. We also know that lower activated CKD patients have almost a 20% higher risk of developing cardiovascular disease. Under improved health behaviors, targeted patient activation interventions can improve adherence to kidney care plans. going over to lower cost of care. We know that increased PAM scores are associated with appropriate use of the healthcare system. And then under better patient self-care and satisfaction, we know that in patients with CKD and diabetes, a higher level of activation is associated with a higher overall level of self-care, and that in higher activated ESRD patients, they report a higher satisfaction with treatment plans and reduced decisional conflict. So after an individual completes the PAM, which the PAM is a 13-item survey that individuals take, care teams can understand the individual's PAM score. And those PAM scores translate to one of 4 PAM levels, which you can see here. So we think of individuals at PAM levels 1 and 2 as being lower activated, and individuals at PAM levels 3 and 4 as being higher activated. For the individuals who are lower activated, we think of these individuals as being kind of passive recipients of care. These individuals are easily overwhelmed by thinking about their health, by talking about their health, by thinking about taking steps for their health. So they get easily overwhelmed, therefore they get easily discouraged when they think about their health, and then they oftentimes disengage from thinking about their health. On the flip side, for individuals who are higher activated, we think of these folks as being proactive in managing their health. These are individuals who have a great knowledge base about their health or health conditions. They have built some really great skills, a toolbox of really great skills to be able to change their health behaviors and to maintain health behaviors. And oftentimes you may see these individuals push beyond kind of typical recommendations for health behaviors. So this slide shows how activation really affects other health behaviors. So we think of activation as really being an underlying construct of other health behaviors, and it really forms the roots of self-management. Supporting an individual's activation can really result in an improvement in a variety of health behaviors. And so this is why activation is predictive of those multiple clinical outcomes that I discussed early on. So such as progression of chronic disease, medication adherence, ED visits, and hospital admissions. So what we also know about activation is that activation levels is not static. Activation can be changed. And we know from experience that lower activated individuals will often see faster gains and greater gains in activation with appropriate support. Now, what are those supports? Those you can see in the middle box here. We know what the strategies are to improve activation. And those strategies are to tailor support to PAM level. So this is the most fundamental and most important strategy. Also setting achievable goals, taking small steps with the patient to build confidence, and telling the patient, voicing partnership, but also explicitly telling the patient to take ownership over their health. And so when we support individuals to gain an activation, that's where we see those improved patient outcomes, utilizations and costs, and satisfaction with care. So now I'm going to discuss some data that we have looking at activation, the PAM, in patients with high risk or at high risk for kidney disease. Over the next few slides, I'm going to talk about a study that we did that is published in the American Journal of Accountable Care. Again, so we know an estimated 37 million American adults have chronic kidney disease, but many of those adults lack awareness. In the study that we published, we set out to really understand and identify awareness gaps, understand how high-risk patients manage their health, and determine where are the opportunities for prevention of progression into chronic kidney disease. So just a little bit about the study design. So this was a survey that we administered, Phreesia administered in conjunction with the National Kidney Foundation in May and June of 2023. You can see that we surveyed 4,445 patients with a diagnosis of diabetes and or high blood pressure or hypertension, but without a diagnosis of chronic kidney disease. The participants were administered the PAM survey and were also asked a variety of questions assessing their awareness for their risk for kidney disease and how they manage their health. And also to understand the degree to which high-risk patients engage in preventative behaviors, we also created a kidney health behavior index and published in this paper. Okay, so what were the findings? So the principal findings you can see here. So the most significant predictors of behaviors to manage kidney health. So we found in our study that the most significant predictors were the frequency of patient-provider discussions about kidney health and also patient activation measured by PAM score. Less significant predictors we found were age, that conditions were managed by a specialist, length of diagnosis, frequency of visits, and then non-significant predictors were race, ethnicity, and gender. So what does this mean? So we found that less activated patients in this study are likely at a disadvantage at every step of their kidney care journey. So thinking back to the journey that May has. So at every step of that journey, less activated patients are less likely to be taking steps to manage their kidney health and possibly prevent progression into kidney disease. So increased patient awareness and potentially an early diagnosis of kidney disease has the potential to improve the quality of life for many patients and then saving them from intensive treatments such as dialysis and reducing overall costs of care. So what does this mean for clinical practice and policy? So encouraging more frequent patient-provider conversations about kidney health would help to support prevention of progression into chronic kidney disease and potentially earlier diagnosis. Also, if patients were more activated and empowered to work with their clinical team to manage their kidney health, this could also help to prevent, potentially delay the progression into chronic kidney disease. And also, these findings could potentially be applied to help patients with other chronic health conditions to adopt preventative behaviors. Now that we've talked about leveraging activation and the patient activation measure in patients who are at high risk for chronic kidney disease but don't have a diagnosis, we'll continue down the continuum of kidney care and talk about patient activation and the patient activation measure in patients who do have a diagnosis of chronic kidney disease and end-stage renal disease. So I'm going to present some data on patient activation taken from evaluation of the Kidney Care Choices model from the first year of the model. So first, what is the Kidney Care Choices model? So the Kidney Care Choices model is a Centers for Medicare and Medicaid Services, or CMS, innovation model that provides financial incentives to improve kidney care for Medicare beneficiaries with stage 4 or 5 chronic kidney disease, so late stage chronic kidney disease, and end-stage renal disease. This model is ongoing today. It started in January of 2022 and will go to the end of 2026. And what is really interesting about this model is the model creators really sought out to make the patient central in the model. So you can see here that the model is the patient is a key component of the model's design. So how is PAM included in this? So a PAM performance measure is included as a quality measure in KCC. And so the way that the PAM is utilized in this model is that model participants, so nephrology practices and dialysis centers, administer the PAM at least twice a year to their beneficiaries, and they also support patients and beneficiaries through activation-based coaching. This slide shows a summary of the PAM results in that first year evaluation of the KCC model. So in the first year of the model, we saw clinically meaningful increases in PAM score, so an average of 8.8 points across patient populations, and the highest increase in PAM scores, 12.8 points, was among transplant patients. So that 8.8 points is in comparison to what we typically see in terms of PAM score increases, and that number is usually around 4 points. In previous studies, we know that this 8.8 point increase is associated with about 8% reduction in costs. Additionally, we saw gains in activation across all patient populations, including older patients, patients who are sicker, patients who are economically disadvantaged, and also patients from racial or ethnic minority groups. In this model, there were also significant improvements in other targeted outcomes that you can see here. So increases in home dialysis, also increases in peritoneal dialysis and optimal starts, and an increase of patients on the transplant wait list. And also, we saw that 85% of large healthcare organizations participating in KCC were able to successfully implement not only the PAM administration, but also the interventions to address the needs of less activated patients. And most of these organizations had never heard of the PAM and had never used the PAM previously. So I just want to close out our time today focusing back on patients and share the story of this patient, Dave, who's an ESRD patient. And you can read about his story at the link on this slide. I have it also on the next slide. But Dave is an individual who had not seen a physician for many years, and he was diagnosed with kidney failure in an emergency room. Diagnosed with kidney failure, and then he needed to start dialysis. He skipped many dialysis sessions. He really had trouble getting to his dialysis sessions, and he also had financial constraints with getting to his dialysis sessions. And so he was labeled as non-compliant by his care team. But he had a meeting with his care team one day, and they told him, you need to do your part to stay alive. And when you read Dave's story, he says that when he was told this by one of his care team members, this was really a turning point for him. He realized that he wasn't just kind of a patient that was passively receiving care, but that he was a key member of his own care team, and he was the central member, the central person in his health. So after having that conversation, he really started down a different road. He began adopting new health behaviors. He started going to dialysis regularly, and he stopped smoking. Eventually, his health improved. He was able to go back to work. He sought out. He got himself on a transplant waiting list, and he received a transplant, and he now feels in control of his health. For the patients who are watching here today, I just want to say that, I think the moral of the story is that you are the most important person on your healthcare journey. And it is so critical for you to take an active role in your health. For those of you who are watching who are clinicians, I'd say start thinking about how you could use the patient activation measure to tailor care, to support your patients, to gain an activation and support them in improving their health. And for those of you who are watching today who are implementers, know that it is feasible to implement the PAM and implement PAM-informed coaching. And it's feasible to incentivize care teams to support patients to make gains in activation. So I've just got a couple of resources here on this slide that folks can go to learn more about the patient activation. Also, I have the citation for the study from the American Journal of Accountable Care, and also the link to Dave's story in the healthcare blog. Well, thank you again, everyone, for joining us today to discuss patient activation and the patient activation measure in patients with chronic kidney disease. Here's my contact information, so feel free to reach out with any questions. You can also visit us at Phreesia.com to learn more about the patient activation measure.
Thank you, Dr. Suh, for your informative presentation. But before you go, I'd like to ask you a few questions. The first question is, you've presented some interesting evidence that activation can play a role in kidney health. What is the main takeaway for the audience today?
Yeah, thanks for that question. It's a really great question because I did present a lot of evidence and data today. I would say that the patient activation measure is a really effective way to center the patient voice in their care. It really helps care teams to understand what is important to the patient, what they value with regards to their health. And it can be used really to help support patients, to make gains in their activation, and ultimately get to better health outcomes.
And finally, Dr. Suh, what has been your experience in working with nephrology practices who are using PAM today?
Yeah, thanks for that question. As part of what I do at Phreesia, I do have the opportunity to work with many nephrology practices and dialysis centers in utilizing the PAM. And so I have definitely seen nephrology care teams really utilize the PAM to tailor their care to the individual's PAM levels, really to provide that support to help patients understand their health, understand their health conditions, understand what the diagnosis of chronic kidney disease means, so that they can start to build their skills to make changes in their health behaviors, which then translate into those individuals really starting to feel success by meeting goals, by taking small steps to make changes, and then they feel confidence to make other big changes, to take steps into maybe discussing home dialysis or having discussions about getting on a transplantation list. So in general, I've seen nephrology practices and dialysis centers successfully use the PAM. And just one anecdote that comes to mind in discussing the use of the patient activation measure with a nephrologist, he said that, he was skeptical about using the patient activation measure in his practice. He didn't think it would provide any new information, but he said he became a true believer after he administered the PAM to one of his patients that he had seen for 10 years. And after administering the PAM, it made him realize that this patient really didn't understand what her medications did. So that gave him an opportunity to connect her with his practice's pharmacy program to really help support her in her kidney health journey. So there are definitely many other patient examples like that. I've heard from care teams that after administering the PAM, it really helped them understand the patient, really get a greater insight into patients and where they're coming from. I heard a story that from one practice that they administered the PAM to a patient who was a former nurse, and the care team member had assumed that this patient had a really great understanding of her health, but after administering the PAM found that individual, was a lower activated individual. So I think in addition to helping care teams really tailor their care, it really brings a new insight and a new dimension for care teams in understanding their patients.
That's excellent. Thank you, Dr. Suh. Thank you so much for the important work you do in advancing care for vulnerable populations. We truly appreciate your contributions to this session and to the broader conversation around patient activation and innovation in care systems. We appreciate your participation in our global summit.